Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy that you chose to spend some time with us. We have an exciting program planned for you today. We will be talking about the rise in, or the reported rise in the incidence of colorectal cancer and how we can what we need to do to prevent it and what we need to do to have early detection. Without further ado, I will turn it over to our founder, Dr. Randall Maxick.
Good afternoon, everyone. Hope everybody's having a great Sunday. Our distinguished speaker today is Dr. Marie Borum, physician, educator, public health person, who is the department chair at George Washington University for gastroenterology. She is certified in internal medicine, gastroenterology, and geriatric medicine. Her clinical research interests include colon cancer, ulcer disease, liver disease, AIDS, GI health for women and minorities, and inflammatory bowel disease. She, with her multiple degrees in internal medicine and geriatric disease, is the director and department head of that division. I did a search looking for a number of department heads at U.S. medical schools. There are very few department heads outside of the 4 historically Black medical schools, so she is truly distinguished. And the fact that she's not only Black, but she is a female, she is in rare air. She did her undergraduate degree at Princeton University. Her medical degree was received from Rutgers Medical School, the Robert Wood Johnson Medical School. She had got a master's degree in public health and her doctorate in education from George Washington University. I present to you the distinguished Dr. Marie Borum. Dr. Borum. Dr. Borum, are you unmuted?
Dr. Borum is on mute, so we need to get Dr. Borum unmuted if we can.
Are we able to do that?
Simon, is Dr. Borum, there we go. Go
Can
ahead.
you hear me? Okay.
Yes, ma'am.
Okay. And so I'm also trying to share my screen.
We can see it.
You can see, yeah, but let me get my slides. Slideshow. I'm just going to put on slideshow. Okay. Can everybody hear me and see me? I am so sorry about that.
No problem. We can see you. We welcome you.
Perfect. I just want to thank you very much for that really kind introduction. I am so pleased to be here this afternoon to talk about colon cancer, because in the United States, colon cancer is one of the most common cancers that we see, and it is particularly prevalent in African Americans. And since March is the National Colorectal Awareness Month, I think this is particularly timely for us to continue the discussion about Blacks and cancer and African Americans and colon cancer. So colon cancer, as we know, is one of the most common cancers, not just in the United States, but worldwide. It is the third most common cancer in men. It is the second most common cancer in women, and it's the fourth most common cancer death. Oh, my slides are stuck. Okay, just a second. In the United States, it is, let me see, I skipped some here. The American Cancer Society estimates that just came out for this year suggest that there'll be more than 106,000 new cancers of new colon cancers in this nation. There'll be more than 46,000 rectal cancers this year, making more than 150,000 colorectal cancers. And it's estimated that we'll have over 50,000 cancer deaths. It is higher in men than in women. You can see that in all races, men have a higher rate of colon cancer compared to women. It is highest in African Americans. It's higher in Blacks than in any other racial group, and certainly higher in the majority. And it's also highest among those with specific inherited disorders. In the United States, it's estimated that 1 in 23 men will get colon cancer, and 1 in 26 women will get colon cancer, with approximately 4% cancer risk. And the risk of colon cancer begins to increase after the age of 40. It increases significantly every decade, 50, 60, 70, and then after age 80, the risk of death decreases because many times people over the age of 80 are no longer dying from colon cancer, but of other comorbidities. So with each decade, colon cancer risk doubles. And the SEER database in the United States and other registries has noticed that colon cancer has increased under the age of 50. And while the median age is estimated to be 67 right now, we have, over the past 2 decades, we found that colon cancer rates have increased after the age of 40 every single year. And so when we look at colon cancer overall risks and death rates, it suggests that colon cancer deaths has decreased over the past several years, but that is mostly because deaths have decreased among older Americans, but younger Americans are increasingly diagnosed and increasingly dying from colon cancer. And the one most unfortunate thing is that colon cancer exists at all, but it disproportionately affects Blacks in the United States. The incidence is higher than in any other racial groups. It is 20% more common in African Americans, and it is 40% more common for us to die from colon cancer. There have been some high-profile Americans that have died from colon cancer, which I can tell you, at least in my practice and anecdotally across the nation, has certainly increased the rate, increased awareness, and have increased the rate of colon cancer screening inquiries. Whether that has actually translated to increased screening, increased detection, and improvement in mortality is not yet known. But we all know of recent cancer deaths among some high-profile people. Quentin Oliver Lee died at age 34 just last December. From Phantom of the Opera, we know. Chadwick Boseman, we know from the Black Panther, died at age 43. And we have other important entertainers and actors who have also passed away. So this has resulted in a lot more inquiries, at least in my practice, and I'm sure in other people's practices, but it affects people across the board. We know that just recently, Congressman McEachin died from Virginia We know that Donald Payne from New Jersey died. We know that Representative Melinda McDonald died from California. So we are clear that colon cancer affects people across the spectrum. And of course, these young men athletes, it was so hard for me just to pick out a few, but I wanted to show how it affects all of us in every walk of life. But from colon cancer, from very young, we look at people in 30s and 40s to those people who are older. So the mean age of colon cancer development in African Americans is younger than in any other population. Notably, African Americans are more likely than any other to die from colon cancer under the age of 50. And most colon cancers develop from polyps. We have a normal colon, we have colon polyp in the middle, and we have colon cancer on the right. 95% of colon cancers come from polyps. And our goal, of course, is to try to find those polyps because those are precancerous. We're trying to get them before they become cancerous and undergo malignant change. And so there's some things that increase our risk for colon cancer that we can't change and some things that we can change. So let's talk about the things that we can't change, but we have to be aware of so we know what our own risk looks like. We can't change our age. 90% of colon cancers will be diagnosed after the age of 50, but in fact, we still have a high percentage of people who will get, we still have a percentage of people who are diagnosed before age 50, and we have to be aware of that, and we have to begin screening. And of course, now we know that screening begins at age 45. We know that men get it more than women, and so both men and women, of course, have to be screened, but we know men are at greater risks. We know when we look at race and ethnicity, we've already shown on those slides that African Americans have among the highest rates of colon cancer mortality, but the rates are also increased in Alaska Natives, in some American Indians, in Ashkenazi Jews. And if you have a personal history of inflammatory bowel disease, that will be Crohn's disease or ulcerative colitis, you have an increased risk. You have an increased risk if you've had polyps before. So if you've had a polyp once, you should have a different screening regimen than if you did not have a polyp. And if you had colon cancer once, you can get colon cancer again. And then we have family history. If you have a family member, a first-degree relative, parent, sibling, child, who's had a precancerous polyp, you in fact have an increased risk of colon cancer. If you have multiple second-degree relatives, you also have an increased risk of colon cancer. If a family member has had colon cancer, or if you have a genetic mutation, you have an increased risk of colon cancer. So let's look at the colon cancers. If you have no risk or no family history of colon cancer, or no risk of a family history of a precancerous polyp, your lifetime risk is about here, about 4%. You can see how it doubles if you've had a family history of a precancerous polyp. You can see how it continues to increase if you have a first-degree relative with colon cancer. And if you've had a first-degree relative under the age of 45, you can see how significant that is in increasing your risk. And if you have more than one relative, you can imagine that that increases your risk. So it's not just having a family history. Depending upon the type of family history you have, you can tell that you can have more of a chance of developing colon cancer, and you have to be particularly vigilant about getting screening. And then you have genetic disorders, which I only want to mention briefly, but it's so important because there are certain genetic disorders that also increase your risk for colon cancer. FAP, familial adenomatous polyposis, where you get innumerable number of precancerous polyps in your colon. And you also have a condition called Lynch syndrome. And the reason I bring this up is that we have recently done research to show that in general, we may not screen for these the way we would like. And we also know that we screen, and it also has been shown that we screen less in African Americans for these conditions. And even though we are affected similarly to others. And then there are modifiable risks. People who smoke have an increased risk of dying from colon cancer compared to non-smokers. So there are many reasons not to smoke, but if you are a smoker and if you're a long-term smoker, you have a high risk of dying from colon cancer, higher than others. If you have a diet that's high in fat or high in red meat, you have an increased risk of developing colon cancer. And so when we talk about moderation, we want to make sure that we eat in moderation, eat red meat in moderation. Excess alcohol consumption, physical inactivity, and obesity are also modifiable risks, things that we can make a difference, and things that make a difference in what we do, and things that we can change that will change our risk for colon cancer. So let's talk about screening. Remember, for many, many years, we always started screening at age 50. And then it became apparent that African Americans had a higher rate of colon cancers developing very early. And so we began screening in African Americans at age 45, after we convinced the insurance companies and our payers to make sure to reimburse for that screening to start early. And it began to make a difference. It showed that we were finding earlier colon cancers. It showed that we were able to treat earlier. And because of that, we found that not only could it make a difference in African Americans, it can make a difference in everybody. So right now, screening is recommended to start at age 45, unless you have one of those other risk factors that you and your healthcare provider can identify that may result in your screening earlier than age 45. And there are different ways to screen. And while colonoscopy is our gold standard, there are other ways to screen, because there's some people who will not or should not get colonoscopies unless it's absolutely necessary. So there's stool studies. The one that's been around for decades has been fecal occult blood testing. That's every year. We have FIT testing. That's every year. And now the one that's been advertised a lot, both in print and in social media and in television, is Cologuard. And that's every 3 years, starting at age 45, and they will reimburse for it up until the age of 50. Of course, if any of those are positive, then you will go to colonoscopy. And then you have imaging. And of course, people will ask us about virtual colonoscopy. So that's scanning either with a CT or an MRI. And those can be done every 5 years. But it's important to know that insurance companies don't automatically pay for virtual colonoscopies. They will only pay for virtual colonoscopies if for some reason a colonoscopy is incomplete or is difficult and you're not able to see the entire colon, or there's some reason that someone should not have a colonoscopy, potentially because of sedation risks, or because it's too tortuous to actually attempt it and the risk of perforation is too high. But imaging studies are generally not reimbursed. Flexible sigmoidoscopy is still listed as a screening option, but we know it's not widely used anymore because you're only looking at part of the colon. And the reason why colonoscopy, of course, is the gold standard is because not only can we diagnose precancerous lesions, but we can take them out at the same time. So the American Cancer Society has identified that colorectal screening is a priority for cancer prevention and for cancer control. And when you look at the statistics, it suggests that screening still remains lower among African Americans. And this data is actually the best of the data. When you look at small studies and multiple other studies, you find that African Americans just are not screened as well as others. But when you look at the general population, we're still a little bit over 60%, which is inadequate if we're going to make a significant difference when it comes to colon cancer screening. And so while colon cancer is the third most common cancer death, we mentioned before that mortality is decreasing. And it's decreasing mostly among older people. But we believe it's decreasing for a variety of reasons. It's decreasing because we're screening more. It's decreasing because when we screen and we find a polyp, we're able to take it out. Whether we screen by stool tests that tell us that we should do a colonoscopy, or when we do a colonoscopy, find a polyp, we take it out. We're detecting colon cancers earlier, so we have a higher rate of survival, and we also have improved treatment. So that's why we believe colon cancer deaths are decreasing. But among young people, it continues to increase because very often the screening isn't done as robustly. And the mortality remains high among Blacks. It's incompletely understood. We know that screening rates are lower. We know that colon cancers are less frequently diagnosed early. There's been some question, there's evaluation about whether the tumor biology is different, but that hasn't been proven completely. But there's always research to determine the tumor biology of different types of cancers, but it may not be ethnically based. And then there are environmental factors that we're always considering, whether there are some of those modifiable factors that may make a difference. And so the earlier colon cancer is found, the greater the survival. Early stage colon cancer has a 90% survival. So when we find a polyp, it's obviously 100% because polyps haven't become cancer. When we find colon cancer within a polyp, we still have well over 90% survival. But as colon cancers get larger, they go through the wall of the colon, they break through and go into lymph nodes, we have less and less survival. Survival declines to 70% with more advanced disease, with only 13% of people surviving with regional or distant metastases. The overall survival cancer rate is 65% in 5 years and 58% in 10 years, but it can be 90% if we screen and catch it early. We found that Blacks with colon cancer are less likely to survive compared to others. We don't have the same survival rates. But when you look at a number of studies that I listed here, you find that very often Blacks don't receive the same type of surgery, the same chemotherapy, the same radiation treatments as others. But when we actually make a protocol based on staging, Black patients have similar survival rates when they're treated the same. We all on this call know that. We all assume that. But there had to be studies to show that if Black patients get the same treatment as others, and this was originally done out of the VA where everything was protocoled, you find that Black patients survive the same rate. So those differences in survival based on treatment disappear. We also noticed that in some studies, in one study that came out more than a decade ago and continues today, is that Black patients who are privately insured are more likely to survive than 5 years after diagnosis than Black patients who are uninsured. So the issue is not the type of treatment. When we get treatment, like everybody else, we survive the same. It's actually getting screened, getting diagnosed earlier, and getting to people who will take care of us. So in fact, African Americans have a higher morbidity and mortality rate. We know that. We know there's a higher incidence rate. We know that they're diagnosed under the age of 50 more than any other ethnic group in the United States. We undergo less screening than every ethnic group. We less often receive recommended treatments, and we have higher mortality rate than any other ethnic group. But there's increasing awareness. And for me, it doesn't matter why we have increasing awareness. Is it because we have high profile people? Is it because those of us on the call and those of us that we know get into the community? Is it because we encourage other people to get screening? It doesn't matter why there's increased awareness, but there is increasing awareness. And with increasing awareness, we have better screening. And we need to screen starting at age 45. Once we're diagnosed, when we receive the same treatment as everybody else, whether it's surgery, chemotherapy, radiation, or a combination thereof, we have the same survival. If we participate in clinical trials, if it's appropriate, that helps. And if we partner with healthcare providers who care, then we can make a difference. So all of us, March is Colon Cancer Screening Month. We need to get screened. We need to get our family and friends screened. We need to encourage our community to get screened because we can make a difference. And I have all of the references if people are interested. Thank you. So I'm going to I can't see the chat questions.
Can you hear me now?
I can.
Now we can hear you, Dr. Maxey.
Okay, let me ask you the first question, Dr. Barham, and thank you so much for your very astute talk. I read an article a few days ago regarding omega-3s. And in this article, it suggested that when people ate fatty fish, such as sardines, salmon, that it would reduce the percentage of renal failure, cardiovascular disease. And I know in your talk, you talked about reducing the fat in your diet. Is that sort of a conflict of the advice to eat fatty fish versus reduce fat in your diet to prevent colon cancer?
When they talk about fats and colon cancer, they're mostly talking about red meat. And it's the fat in red meats, not in the fish, that have been best studied. And I remember looking at this a number of years ago when I used to do laboratory research, decades ago, when we looked at contents in predisposed animals in their diet. And it's really the red meats and a high-fat diet that makes a difference. Fish has not been studied the same way meat has, and has not been part of that, has not been part of the discussion as about increasing colon cancer rates. So it's really the red meats, processed meats, that people have the most concern about when it comes to colorectal malignancy.
Dr. Hines, you're the closest to DC.
I'm sorry?
I said you're the closest to DC, Dr. Hines.
Yeah, I'm trying to get off mute. Am I on mute?
No, you're not. We can hear you.
Oh, okay, great. So thank you. That was such a great talk. I learned something today too, because I was like, how come if you missed your Cologuard time and you're over 50, but it was an insurance issue? At the very end of your talk, you were listing some people that you could partner with. And I missed that last one. Who did you say was someone that people could partner with in the context of looking for people to take care of you?
Right. So one, I think the message that I want to make sure that we give is that when we take care of our patients, that we make sure that we partner with other providers who care as much as we do, right? Because when you find, and it's most alarming, that Blacks are not surviving as well as others because they're getting different treatment, it's wrong. It's unfortunate. It shouldn't be. So when we make sure that we are partnering with people who use the same protocol as they do on everybody, the VA was the one who started that. But when you go to academic centers and you go to providers who are not at academic centers, but you trust and care, and care for people the same way we do, we find that we have the same survival. So it looks like in fact, in earlier studies, it suggests that the biology may be different among African Americans, biology of the tumor. Well, in fact, it may not be the biology of the tumor that makes the difference so much. It's actually getting the appropriate treatment. So there are tumors that have different biology, but it doesn't look to be ethnically based. But when we actually get the treatment based on the histology, based on the microsatellite instability, based on the other parameters that everybody else does, we do just as well. We just have to get all of us in for screening.
It's disturbing and reassuring at the same time, right? Like, because the fact that there are already protocols that exist. So
That's
the
right.
fact that folks are choosing not to is disturbing and reassuring.
And they're good protocols.
Yeah.
The protocols for colon cancer are good protocols. We have a survival rate that is significant for even when we have regional disease. We have more than a 67% survival rate, even for regional disease. Distant disease, we don't do as well, but we have good treatment. And we have to just make sure that we get people to good treatment.
Dr. Abrams-Stephen, are there any questions in the chat we need to address?
Yes, but I want to ask a question before we go to the chat. Dr. Borum, I want to push you a little to get down into the nitty-gritty of the diet and not only the fatty foods, but how food is prepared, the issues or the suggestions that have been made that charred food contributes. Could you get into more of the specifics about the cooking of the food as well as the variety of foods?
Don't mess with my barbecue, Dr. Neighbor.
Yeah.
Yeah, and your steak and everything else.
Yeah, certainly, because that has been looked at. And in fact, when we look at some of the cancer organizations that are looking, or the nutritional organizations that are looking at food types and diseases, when it comes to colon cancer, the first thing that everybody says across the board is red meat. And so we understand the whole issue of red meat. But then some of the nutrition organizations have gotten a little bit more detailed than that. They have gone on to say it's not just red meat. Some of the issues with meat has also been processed meat, which is particularly alarming. So processed meat has a high rate of cancer risk increase. And then we have the whole issue of the barbecued and the charring of the meat and cooking on grills. And that also is thought to increase your risk for colon cancer, and as well as other potential cancers. So it's red meat, it's processed meat, and it's the way meat is cooked, the high heat, the charred, the barbecued. So it absolutely has to be suggested that it be done in moderation. It's very hard to tell people that you absolutely need to go on a plant-based diet. And while that has been the overall nutrition organization's recommendations, that's not something that everybody can do or that can be tolerated by people. So moderation is key. Moderation is important, and knowing how you actually cook foods is critical. The other thing that has been, as far as diet, we know that maintaining adequate calcium in your diet is important. And so we also know that fiber is important. So many decades ago, when I was actually doing laboratory research, and what has continued to bear out in studies much more elegant than mine, you find that people who have high fiber in their diet, both in animal studies and in other studies, may have a decreased risk of colon cancer. And they did that study in people who had genetic predisposition, and found that if they're in a high fiber, adequate calcium, low red meat diet, they actually did better. We find that alcohol in moderation is key. And while we don't want to tell people to completely change their lifestyle and diet, is the things that have been demonstrated to be important are making sure that you are eating meat in moderation, that you're having adequate calcium, adequate vitamin D, high vegetables and fiber, and decrease your alcohol and as the major dietary impact when it comes to colon cancer development and survival.
Now we have two interesting questions in the chat. The last one tags on to what you just said about highly processed meat. When we've had other conversations on this program in the past, discussing and questioning, is there any increased risk in eating the highly processed plant-based foods like the fake beef and the other imitation foods?
Right. So,
so what's your take on that?
yeah, so that has become an increasingly talked about and researched area and research in progress, because one of the things that many people wanted to do was to say, let's take out the red meat and let's use meat substitutes. But the meat substitutes have high fat in them. I mean, and so the whole question is, are we substituting one bad fat for another bad fat? And so, in fact, that is something that is actively studying, has not been studied well enough or robustly enough in regards to colon cancer specifically. But theoretically, and what we've begun to talk about is that fat of any high fat, no matter what the product, except for fish, which is sort of taken aside, high fat may actually be a risk, modifiable risk for colon cancer development.
Dr. Walks?
Thank you, Dr. Maxey. Dr. Bourne, thank you so much for giving us some real direction and instruction in what to look for as we go through our lives, concerned about this very, very challenging condition. There are a couple of things. One is that Dr. Thomas has put quite a bit in the chat.
Yes, I was just reading that.
I'm not a multitasker, so it's hard for me to read and listen at the same time. But there are some comments in there that maybe we can get to, or maybe Dr. Thomas has finally found a way to talk to us, because the last couple of weeks he's been unable to talk to us. So maybe Simon, you can see if we can unmute Dr. Thomas.
So let's start with the beginning of the chat, if you want. The first question I see from a Dr. Gibson is something about genetic liability for African-American patients.
Mm-hmm.
And one of the things we believe with African-American patients, as research has gone on, is that it may be less screening that is done, less access to screening and not identifying colon polyps or colon cancers as early as in others. But I also want to bring up just that small mention that I had of genetic susceptibility with certain genetic disorders, because we know over the years there have been an increasing number of genetic tests that allow for us to look at a whole array of mutations that can occur affecting many different diseases. And as those genetic tests have developed, we have found that, in fact, GI cancers or colon cancers are among those tests that we can actually test for. The two most common ones are FAP and Lynch syndrome, which can now be genetically tested on the standard genetic mutation tests that are available. It turns out that when we did a study at GW, we found that people were not asked about, because in order to get those tests, in order to get those tests covered, you have to demonstrate that you have a family history that may predispose you to that. So what's important is that a detailed family history is taken. What we found, at least at our institution, that a detailed family history was not always done across the board. So that's one issue, but it was done less frequently in African Americans. And we, in fact, have the same susceptibility, or we, in fact, have the potential to have those genetic disorders and mutations also. So I think it's important in those places that do have EMRs to make sure that We can not only screen, as is recommended in everybody over the age 45, but we also do the evaluation that needs to be done to see if there is a genetic predisposition or liability. Because those people who have those genetic mutations, in fact, have a greater risk of developing colon cancer, need to be screened earlier and more frequently. So in fact, it may not be that there's more of a genetic liability, but it may in fact be that we are not asking the right questions. So when it comes to trying to figure out who should get screened, it doesn't matter to me how you get screened. The best screening test is the one that's done. And so I think it's just important that that all happen. And when we go to Dr. Thomas's questions or comments, which are so very important, it said that individuals should discuss their screening options with their healthcare provider to determine what's the best screening method, because some people do not want or should not get or are unable to have options to get colonoscopy. But that doesn't mean that just because you can't get a colonoscopy, you can't get screened. And I think it's important for people who may be reluctant to get a colonoscopy to understand that there are non-invasive testing that's available. And while Cologuard was previously not covered, it is absolutely covered by insurance companies now. And it's absolutely covered even by government insurances. And they have now, as of a few years ago, allowed us to begin to use that starting at age 45. And so, in fact, one can get Cologuard and can get FIT tested every year, or can get Cologuard every 3 years, and that can be covered. And so that way people can choose what kind of test makes the most sense for them. And very often you find that people who may choose to get stool testing, which is important, and it becomes positive, that gives them the option or the understanding or the appreciation that colonoscopy may be a good test for them.
Dr. Borum, on that point, even though I'm a physician, I'm a Black man, and I was abhorred about thinking I had to get a colonoscopy. I subsequently have had 3. But can you give us an idea for the layperson, what is actually involved in a colonoscopy and why it may not be as threatening as they may think?
Sure.
Before you answer that, can I also ask that you include comments on the prep? Because the prep
Yes.
is oftentimes a place where people get very much deterred.
Absolutely. That is absolutely one of the biggest obstacles, because the prep is something that is the most difficult part of the procedure. So for a colonoscopy, the colonoscopy itself is a procedure that is done under sedation, generally is under sedation, and it's a procedure in which one does not feel and it's not uncomfortable because there's sedation. The worst part of the prep is getting ready for the colonoscopy. And to get ready for the colonoscopy, you have to make sure that you are adequately cleansed. And so one of the things that we have to cleanse is very often a really large jug of a laxative, which seems to be quite intimidating. One of the things that has been helpful in recent years is that we now have low volume preps, so you don't have to have the same jug of laxative, low volume preps that allow people to get adequately cleansed prior to their colonoscopy. One of the things that I often recommend, because if you are not adequately prepped for your colonoscopy, then you have to do it again. And that's exactly what you don't want to do. And so what I will often ask people to do is to make sure that they have a diet a week prior to their procedure that ironically is low in fiber. I ask people to have a low fiber diet, a low residual diet, and to go on soft foods so that when it comes time for that vigorous prep, the colon doesn't have to work as hard to get as much out. So I ask people to go on 5 days of a low residue diet, a soft diet. And I ask people 2 days before the prep to take an over-the-counter laxative, Dupalax or Miralax or something to help. I think of it as helping things get started. and then the day before on a liquid diet. And while that feels like a lot to do, once we get to the point where we take the prescribed laxative, we are now ready for our procedure. And if that procedure is good, it's every 10 years. So the hardest part, indeed, as you mentioned, is the cleansing part. Getting cleansed adequately for the procedure is probably the most intimidating, but it's the one that you can control. The procedure itself is under sedation. You sleep through the entire procedure. You don't feel anything. And in fact, you don't remember anything after the procedure. And right after the procedure, you will know most of your results. You will know if a polyp has been taken out. You won't know the type of polyp, but you'll know what was found during your colonoscopy. So in fact, I encourage people to get colonoscopies because if they're normal, it's every 10 years. If it's a polyp, depending upon the type of polyp, we'll tell you when you need to come back. But in fact, the procedure isn't hard. It's the prep that's difficult.
Dr.
Thank
Borum,
you.
I remember when I had my first colonoscopy, I had an IV in, and the doctor said, I want you to count down from 10. So I said, 10, 9, 8, how long will this take? He said, we've been waiting for you to wake up for the past few minutes. It's all
That's
over.
right. That's right. Most people do not remember the procedure at all. And the type of sedation that people use is makes it so that you have amnesia for the procedure, and then you wake up. And so you don't remember the procedure and you don't have any discomfort.
So what words of wisdom to summarize all that you have told us that we can do to cut our risk and also make sure we're getting adequate diagnostic treatment and diagnostic therapy for colon cancer?
So the words that I would like to leave people with is to make sure that we get screened. Screening is critical. And I think screening is going to make all the difference. And when we had the turn of into a decrease of colon cancer deaths, that was felt to be as a result of screening. So it's critical that when one goes to their healthcare provider, and obviously there are issues related to that, it's important that people have healthcare homes. It's important that people have a provider that cares for them, and not only is going to take care of them in general, we have to make sure that colon cancer is part of the screening that is done, or is part of the list of things that has to be done to maintain optimal health. So screening is key, and screening as frequently as indicated by your own personal risks are important, and making sure that we reach out to those in our family, friends, and community to make sure that screening is done. It's also important that those in the community, and those of us who do primary care, those of us who do gastroenterology, those of us who see anybody, because everybody needs to get colon cancer screening, make sure that we, if we can, identify others in the community who care as much about your patient as you do, and will take care of those people who have been identified to have early stage colon cancer, or to take care of those polyps as frequently as appropriate.
So Dr. Borum, I want to get at your public health hat a little bit, and I was looking at one of the comments that Dr. Thomas put in about the places people are. So the beauty shops, the beauty salons, the barber shops, and connecting those folks. I know folks who will drive 45 minutes to go to the barber that they think is their barber that does a good job. So they're clearly people that have a hairstyling home, and we need them to have medical homes. So a couple of comments on that, and a couple of questions on that. One is, can we, or are we, a place like GW that has a huge footprint in a huge regional footprint. Does GW have those kinds of community outreach programs to partner with folks? It's like the old saying, why do you rob banks? Because that's where the money is. So it's sort of getting to where people are. And then the second piece of it is, I know I should not be going to Popeyes. I know I should not be drinking root beer. I should be drinking something green that came out of a juicer. I know all of that. And Dr. Maxey has mentioned sardines a couple of weeks now. But if the risk is only 4%, I got a 96% chance. I'm being basic. I grew up on 39th and Western in LA person now. I got a 96% chance that I can go to Popeyes, I can drink whatever I want to drink, and I'm going to be fine. So how do we, from the public health side, one, get to the people who are interacting with our folks, and then two, get a message that says, just because it's 96% that you're going to be okay, doesn't mean that you need to just do whatever you want.
That's right. That's right. And, you know, when we talk about having a medical home, which is critical, it's critical that our country do better in making sure that people get medical homes. It's critical. But we say, how do we reach that community? And how do we reach our community? And I know that we certainly have outreach programs at GW, but everybody isn't as committed to going into the community and making sure that everybody gets what they need. And so when you look at the studies that happened with blood pressure control, that was among the first studies that was done in barbershops and in hairstylists, and you found that you made a difference. You find that those are some of the same communities and same places that we can offer information. And when you offer information, many times people are nervous about the information or don't know what it entails. And a stool study, a stool test is something that can be done at home. It can be done, and it's very easy to do, and it's non-invasive. And if one does not want to go to or cannot get a colonoscopy, a stool study is something that may be the most appropriate test for them. So it's important that we go into the community and not just sit in our offices to make sure that we reach everybody that needs to be reached. And so, and also as I work with some of my young physicians, we're going on social media, right? I put my younger faculty in charge of making sure that we reach everybody in the way that is most appropriate to reach them. You know, and as I talk to many of my colleagues and they say, well, let's get television ads. Well, my children don't watch television, right? They're on social media, they're streaming, they're not looking at ABC. And so I think it's, or whichever network you choose. Right. So I think it's important that we are flexible in making sure we reach where we need to reach. And in fact, going to places that others may not think of will make a difference. And I so agree with all the comments in talking about that specifically.
Thank you.
As we reach our closing time, I'd like just to ask you a question. What is your program and other programs? What's the future for African Americans in the field of gastroenterology? I'm concerned that I haven't seen many young people in training in that field. Am I wrong?
Yes, gastroenterology is an area that has particular challenges in making sure we're maintaining diversity. So in fact, when you look at gastroenterology in general, at least in the medical subspecialties, it is the most difficult specialty to go into. We have a high percentage of people who will not what we call match into gastroenterology. So we find that it's very difficult to get in, and all the obstacles that we face as a minority group, it continues to exist. We find, just as an example, in my program, we offer 2 gastroenterology spots a year. We have over 550 applicants, and we only take 2.
Wow.
When
Oh.
you look at gastroenterology in general, it is the subspecialty in medicine that has the least number of women in it compared to every other medical subspecialty. And when you look at the number of African Americans who are at least applying, getting to the point where they have not been discouraged and are actually applying, you find that we have very few. This year, we had no African American men applying to our program.
Wow.
And our program is such, the applications are now electronic. You don't have to visit. And one of the things that I make sure that we will continue to do is to do virtual interviews, because one of the obstacles we had was people traveling to visit. And so we do virtual interviews, but still we have a high number of people and a low percentage of people who get in, and a low percentage of women, and a low percentage of minority populations. We have very few African Americans, we have very few Latinos, and we had no Native Americans, we had no Alaska Natives. I think, and I don't think we're alone. We're in Washington, D.C. We're not we are a geographically diverse community, and we still have our own challenges. And so, unfortunately, we have a circumstance where we need to do much better. And I'm trying to do that by not only representing gastroenterology as best I can, but going to the organizations that will allow us to mentor people starting not as a third-year resident, but but in high school, to go into medicine, to encourage them in college, and to making sure that they know that all fields are available to them.
Yeah.
And I thank you for asking.
Again, I just thank you so much for giving up your valuable Sunday afternoon to address us. Dr. Hines, what are your closing comments?
You're still on mute, Dr. Hines.
All right, sorry. Similarly, I'm very grateful for this talk, because it was very clear cut, and I really appreciated the point that you brought home, which was about, even if you're not going to get a colonoscopy, you can still get screening. And I also kind of heard the reverse, which is the easiest method is not necessarily the gold standard or the best method. So I appreciate you explaining the options to us so clearly, and the things that we can do, the ways that we can make an impact on our own lives as well. So thank you for your time.
Dr. Ivan, my doctor.
Dr. Maxey, I will cut down my trips to Popeyes. Dr. Borum, just
In moderation,
again,
sir. Down moderation.
yes, ma'am. Yes, ma'am. Moderation. I just wanted to thank you for bringing the message to the people. We have a diverse audience. We do have other physicians on the call. We have folks who are not physicians. We have folks who are in the pharmacy area and others. And I think when we get a talk like this that has a tremendous amount of clarity, my favorite word, and folks can grab into it and take it and use it. And I think that helps a lot. The one other comment I want to make is, it sounds like a couple of times today, what I've heard from you is that we really need to look at our resources, our system, what's available to folks. Where are those partnerships between the town and gown, the academic institutions, and the folks who are out there seeing folks? We don't have enough primary care folks in many of our communities. So there's an opportunity for us to continue to ask the question Dr. Maxey asked about, how do we get folks into this kind of a program? Some of the comments that Dr. Thomas put into the chat about how do we make sure that we know that there are these barbershop and beauty salon kinds of partnerships out there, and how do we increase those? So there's an opportunity for us to make the system move in the way we need it to move. And it's something that we take very seriously here on Black Health Trust. So thank you so much for bringing out that part of it. It's not all doom and gloom. It's not that the minorities can't get in, the minorities are getting sicker, the minorities are dying faster. All of that may well be true. And at the same time, we can do some things to guide the oil tanker. It's hard to turn it, but we can guide it a little bit.
Yes, indeed.
Thank you so much. Dr. Barbara Neighbors-Stephens, including your final remarks, can you talk about some of our upcoming programs you know about?
Okay. So thank you Dr. Borum, you hit the nail on the head. It's a message that we need. I think the death of Chadwick Boseman grabbed some people's attention, and we need to ride that wave and bring the message home that this is affecting all of us, and we need to not think of it as an old person's disease, but rather it is something that all of us need to be concerned about and do something about. And it's something, unlike some of the cancers and other diseases, there are some things we can do actually that will either prevent or lead us to an early detection and improve our outcomes. So thank you. Now, to answer your question, Dr. Maxey, we're going to be talking about oral health and the importance of oral health in the African American community. We're going to be talking about some of the controversies, and it seems like every time you think things die down, a new question pops up around breast cancer. Now, we've been talking about breast cancer a lot, but there's some new things that may be concerning or confusing. So we want to address some of those issues. And then we're going to have a session on eye health. We have a high incidence, a disproportionate incidence of glaucoma in the African American community. And all of us, if we live long enough, probably will have cataracts. So, but there are other things as well that we need to be concerned about. So we're going to be talking about eye health as well in the near future.
Thank you so much. And also on April the 2nd, we have Dr. Edmund Chapman, who's going to talk to us about the fentanyl crisis. We have a lot of our young kids, especially, who are out at parties taking pills. They have no idea what it is, but if it's laced even with a small amount of fentanyl, it can be deadly. And Dr. Ivan, I would like at one point to deal, why are these kids taking random drugs? We don't need it today, but I'm concerned about that trend. Seems like we should have more education to how our kids handle themselves. I'd like to thank everybody for their time this afternoon. Enjoy the rest of your Sunday. Thank you very much, Simon, and all of our co-moderators. And thank you especially, Dr. Borum.
Thanks, everyone.
I really appreciate the invitation.
Thank you.
Goodbye, everyone.
Goodbye.